Good afternoon and welcome to ICE webinars. Today we are joined by Dr. Marc Inciardi, Associate Professor of Radiology, Breast Imaging Section, University of Kansas Health System. Marc specializes in breast imaging and intervention and was an early adopter of automated breast ultrasound technology. He has published articles, given various regional and national presentations, and has served as a peer educator for automated breast ultrasound. ICE webinars would like to thank our sponsor, Seno Medical Instruments. Seno Medical Instruments is a San Antonio, Texas-based medical imaging company committed to improving the efficiency and reducing the complexity of breast cancer diagnostics through its new modality, Opto Acoustic imaging. Approved by the US FDA in January 2021, with supplemental approval in June 2022. Seno's Imago breast imaging system is a new modality combining light, sound, and integrated AI to provide information not previously available to the breast imager. The result is substantially improved confidence in diagnostic results that leads to real-time assessments, streamlined care pathways, and reductions in false positive biopsies. The company was recently recognized by Frost & Sullivan with its 2023 Enabling Technology Leadership Award for its innovative approach to diagnostic imaging. So to learn more about Seno Medical's OA US imaging technology and applications, please visit senomedical.com. Just a reminder to save the date for our 2025 ICE Expo, which will take place at the Rosen Plaza Hotel, Orlando, Florida, February the 22nd to the 24th. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. So for more details about that, please visit attendice.com. Today's webinar is eligible for one Art Category A CE credit by the HRA, and you can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar, and you must complete the survey to receive your 1 CE credit. You'll be able to download the certificate directly from your computer once the survey is submitted, and if you have any questions, you can reach us at webinar@mdpublishing.com. We'll wrap up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. And just for a little bit of fun, let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. April is National Pecan Month. Which state is the largest producer of pecans? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, Dr. Marc Inciardi is our presenter today, and he will be discussing optoacoustic imaging, a new modality in breast cancer diagnostics. Marc, you may begin whenever you're ready.
Thank you for the kind introduction. I'm excited to be here to introduce to you a new kind of breast imaging called optoacoustic imaging, which I believe has the potential to significantly improve our evaluation of breast masses. Now, some of you may know that I have a passion for breast ultrasound screening and have been involved in research in automated breast ultrasound, or ABUS, since 2009. When ABUS was approved for screening in 2013, it was a bit revolutionary both for its intended use in ultrasound screening as well as its design as a volume acquisition. Optoacoustic imaging is similar in some ways, but also different. It is also a novel technology, as was ABUS. One difference is that its intended use is not for screening, but rather as a diagnostic tool for breast imaging. More importantly, this technology has the potential to radically change our approach to how we evaluate breast pathology. Let's start this off by evaluating this image. Here I'm showing to you a highly suspicious mass that everyone would want to biopsy. My question to you today is, how would you measure the size of this mass? Would you measure the hypoechoic diameter, or would you include some additional tissue on the boundary of this mass? This is not an uncommon question that comes up when teaching our residents. The correct answer is B. The measurement should include both the hypoechoic central nidus as well as some of the abnormal tissue surrounding the central nidus, which we call the boundary zone. This is to illustrate two important points. First, ultrasound has long been criticized for undermeasuring breast masses and not appreciating the true extent of abnormal tissue surrounding the hypoechoic portion of the mass. Second, as we delve into our discussion of optoacoustic ultrasound, I will show you that this boundary zone plays a very important part in the evaluation and diagnosis of breast lesions. We will start with a brief review of the BioRads assessment categories. This will lead us into discussion about the challenges of breast imaging and why optoacoustic imaging can be helpful as an adjunctive diagnostic test. We'll talk about what optoacoustic imaging is and how laser and ultrasound fusion work. Ultrasound imaging has a unique display, which is a 6:1 format, which can be a bit intimidating at first, and we'll spend some time looking at this. In both grayscale ultrasound and OA, there are different zones that we can evaluate. We're really going to talk a lot about the importance of looking outside of what BioRads considers to be the mass, which is the hypoechoic area, which we call the internal zone. It turns out that the boundary zone is the most important zone to evaluate, but unfortunately, BioRads 5th edition got rid of the boundary zone. External to the boundary zone is the peripheral zone, which is important for prognostic markers. With OA, we use video sweeps across the entire lesion, and we'll look at why this is important. Some may think that OA is similar to Doppler, and we'll talk about how OA differs from Doppler. We'll have a brief introduction to benign and malignant findings as seen with OA. Lastly, we'll see how we can improve our diagnostic ability with the use of artificial intelligence. Let's first review the BioRads assessment categories and how they are used to guide us to recommend biopsy of breast masses. BioRads 1 and 2 are, of course, the normal and benign assessment categories, which are straightforward. BioRads category 3 is our probably benign assessment with a likelihood of malignancy of 0 to 2%. And BioRads categories 4A, 4B, and 4C give us a likelihood of malignancy ranging from above 2 up to 95%. If we think about these numbers in reverse, this means that between 5 and 98% of biopsies for these assessment categories result in a negative biopsy. It would be a significant clinical benefit if we were able to identify a subgroup of patients that have such a low likelihood of malignancy that they need not to undergo breast biopsy. In addition, patients with a BioRads assessment of 3 undergo biopsy or follow-up. Once again, if we had a better way to predict these patients, which of these patients really needed biopsy, and which were actually benign, it would be a significant clinical benefit for women if we could reduce the number of negative biopsies. The functional and morphologic evaluation with OA depends upon neoangiogenesis. So this is just a schematic showing a small cancer growing on the left. The cancer is just a small ball of cells growing slowly, initially without its own blood supply. At a millimeter, it's too small to generate angiogenesis. The middle image is showing maybe a 2 millimeter cancer just beginning to develop neoangiogenesis. Now at this point, there may not be enough neoangiogenesis to be detected by OA. There has to be a certain baseline amount. On the right, maybe this is a 4 millimeter nodule, and now there's enough neoangiogenesis for OA to demonstrate it. The smallest cancer that has been detected to date with OA is 3.5 millimeters. So what is optoacoustic imaging? It's a dual fusion imaging. It's a fusion of modalities. We send laser light in and receive ultrasound back out. But it's also a fusion of morphology and function. The morphology obviously comes from grayscale ultrasound, but also comes from OA demonstration of vessels and the morphology, which helps us determine whether they're malignant neovessels or some sort of normal inflammatory vessel or just normal vessels. With dual laser frequencies that stimulate both oxyhemoglobin and deoxyhemoglobin, we are able to detect relative degrees of oxygenation and deoxygenation that we see within the region. This gives us the functional aspect. Now, why did we choose to put laser together with ultrasound? Mostly because it's more affordable. It's also widely available and well accepted by patients and non-invasive. It would have been theoretically possible to have laser combined with CT or MRI, but then it wouldn't be as available, it'd be too expensive, we'd have all the same access issues we have with MRI. Other functional tests that exist include contrast such as MRI and BSGI, which uses the radionuclide, which is radioactive. PET-CT and PEM require a pretty high dose of radiation, not just to the breast, but to the entire body, including the bone marrow. And then there's contrast-enhanced digital mammography, which is functional, but again, we'd rather not have to use contrast and radiation. And most of these tests are pretty expensive. Now, this is a contrast-enhanced ultrasound examination of a grade 2 cancer. You're beginning to see the cancer fill in the center, and you're seeing some peripheral radiating vessels feeding and draining it. And inside that white dotted line, that is the internal zone of what we consider to be the mass. But you can see a tremendous amount of this neovascularity occurring outside of what we consider to be the mass. In fact, the vast majority of what we recognize are morphologically abnormal vessels. These boundary zone new vessels are termed whiskers. These are new vessels that are oriented perpendicular to the surface of the internal zone. The boundary and peripheral zone vessels are all morphologically abnormal vessels. With OA combined with ultrasound, we don't have to inject any contrast or use any radiation. We have the high spatial resolution of ultrasound, which is below a millimeter. It's present in every breast department, and virtually every breast imager has to use ultrasound. So they're familiar with the user interface, and with training, it's been pretty easy for breast imagers to incorporate OA into the workflow. This is a schematic showing a handheld duplex ultrasound probe. One of these cords is a fiber optic cable to bring in the laser, while the other is for ultrasound. We can think of this as 4 individual steps that are occurring to make all of this happen, but it all happens in real time. Step 1 is sending laser pulses at 2 different wavelengths designed to be absorbed in both oxygenated and deoxygenated blood. In step 2, the hemoglobin absorbs the laser light, causing thermoelastic expansion of the blood vessels within the breast. In step 3, this expansion of the blood vessel sends a pressure wave back to the sound transducer, which really can't distinguish a pressure wave from an ultrasound wave. In step 4, the transducer interprets the expansion wave coming back from the vessels as sound. So it's laser in, thermal expansion, and sound back out. Now, this is done at very low frequencies. The probe extends the range down to 1 megahertz to detect the pressure wave. So we go all the way down from 1 megahertz up to 18 megahertz. This is a schematic showing the absorption frequencies of both oxygenated and deoxygenated hemoglobin. On the left, the OA shortwave represents the deoxygenated blood with a peak at 757 nanometers. This will be displayed as red. On the right, we see the OA long wave with a frequency of 1064 nanometers, which is the oxygenated blood. This is displayed as green. So the laser frequencies used for excitation are 757 and 1064 nanometers. If you notice, 1064 is not the highest peak for oxygenated blood. The highest peak is here. Rather, it was chosen to give a better separation from the water component of the breast tissue. The colors assigned were originally designed to be as simple as a stoplight. Oxygenated blood is green, and that means go. You don't have to worry. Deoxygenated blood is displayed as red, and that means stop. You should worry. But that's just a general rule. And in fact, that's just a functional rule. You still have to look at the morphologic rules as well. So we'll talk more about red versus green, how it relates to morphology. The morphology that we see with OA is going to come from ultrasound, as well as the demonstration of blood vessels and the morphology. And the morphology is going to tell us whether they're suspicious for malignant neovessels, whether they're inflammatory hyperemia, or just normal vessels. So here we're seeing a case of a small 6 millimeter grade 2 invasive ductal cancer with the 3 zones drawn in. Hypoechoic nidus represents the internal zone. The thick echogenic rim represents the boundary zone, and further out we have the peripheral zone, where there are interrupted tissue planes and hypoechoic spicules. On OA, we can see that there's a lot of red in the internal zone and a red blush in the boundary zone, indicating deoxygenated blood. And in the peripheral zone, we can see that there are green vessels that are oxygenated and they are radiating, which means they are parasitized native vessels. Tumor vessels are usually red, but parasitized native arteries can be green. So we're seeing findings in all three zones in this grade 2 invasive ductal cancer. We have intense deoxygenated blush in the internal and boundary zones and parasitized native vessels in the peripheral zone. Histologic correlation has shown that the blush occurs when there are innumerable tiny vessels too small to be individually resolved. Here's a case where morphology and function agree. We call this a concordant finding. This is suspicious in both morphology and function. It's got a lot of red vessels indicating deoxygenated blood. It has way too many red vessels inside the lesion, and they're polymorphic, meaning they vary in size and shape. We have a tiny one next to a huge one, next to a medium-sized one. They also vary in orientation, so size, shape, and orientation differ in this lesion. This is a triple-negative breast cancer. Most of the findings are internal, which is not uncommon with high-grade cancers. To summarize, the vessels are morphologically abnormal, and the functional aspects show intense deoxygenation consistent with a malignancy. So here's the ultrasound machine, or what we call the Imago machine. It looks like a typical ultrasound machine, with the exception of the 6-on-1 display and, of course, the laser component. Approximately 2/3 of what's in the machine is laser hardware. There's a very high resolution display because it displays 6 simultaneous images at once. The ultrasound transducer is in the center, and there are 2 quartz laser windows on either side, and both wavelengths fired out of both windows. It's important to point out that the Imago machine also has a regular standalone 5 to 18 megahertz transducer. This is important because the majority of breast ultrasound cases, probably 80% or so, can be imaged with the standard probe as they are assessed as a BI-RADS 1 or 2. It's only in a minority of cases in which a suspicious mass is detected that one would need to proceed to image the mass with the Imago probe. So this machine also functions just like a standard high-resolution ultrasound machine, with the advantage of further interrogation with OA when it becomes necessary. Both probes work in duplex mode, meaning with the OA probe, one can fuse real-time ultrasound with Doppler, or real-time ultrasound with elastography, or real-time ultrasound with OA, but not in triplex mode. This is a close-up of the probe. The ultrasound frame rate is anywhere from 20 to 50 frames a second. The laser pulses are fired at 10 pulses per second because we have to allow enough time between the pulses for the heat generated by the very brief energy laser pulses to dissipate, to diffuse to the surrounding tissue, and also to be carried away by the flowing blood. Most of what's getting heated is the blood, but as the blood flows, it carries the heat away. If the frame rate is too high, there can be heating. With the current technology, there's less than a 1 degree change in temperature no matter how long we scan. But just so you know, there's a discrepancy in the frame rate. It's slower for OA because we have to allow time for the heat to dissipate. This is a brief video representation of what happens with OA. We fire 2 laser pulses that cause thermoelastic expansion of the blood vessels, which creates a pressure wave back to the ultrasound probe, which it detects. This takes about 200 microseconds. There are 10 laser pulses fired per second, 5 on the short wavelength and 5 on the long wavelength. So since you need a long and short wavelength to create a single frame of OA, the actual update rate of OA is 5 frames a second. This is the display showing the 6-on-1 presentation. The real-time ultrasound image is in the upper left corner, and we have 5 OA maps. The 2 black and white maps on the right are the shortwave and longwave map. So the shortwave, remember, gives us the deoxygenated blood, And the long wave gives you the oxygenated blood. So anything brighter in the short wave will be colored red, and anything on the long wave will be covered green. You can see that the peripheral radiant vessels are displayed as green, and the tumor vessels in the center of this grade 2 cancer are displayed as red. The OA combined is cleaner, better for downgrading masses, but is filtered a little bit, so it's a little less sensitive. The two color maps in the center are created by comparing the OA shortwave and longwave maps. The OA relative map is the most sensitive map, but it gives you the background signal. When we analyze OA images, we really have to look for boundary and peripheral zone findings. One problem is that the BioRate's 5th edition strongly emphasizes the hypoechoic central nidus and has completely gotten rid of calling attention to the boundary zone, and the peripheral zone is just described as associated features. And so those performing breast ultrasound, the radiologists, sonographers, and mammography techs who are accredited to do ultrasound tend to look for the hypoechoic nidus and tend to overlook these additional important findings. Again, the region inside the white line is the internal zone. The thick echogenic rim, or the thin hyperechoic capsule and benign lesion, represents the boundary zone, shown here between the white and aqua lines. Outside the aqua line, or the boundary zone, is the peripheral zone. What was learned early on, that if radiologists were allowed to score inside out, they stayed within their comfort zone, and they missed the external features such as the echogenic rim and the hyperechoic spicules. And so everyone's so focused on the hypoechoic central nidus that they tended to miss boundary zone and peripheral zone findings too often. So there is a very simple solution. If they're asked to score the peripheral zone first, and then the boundary zone, and lastly the internal zone, they do a good job at picking up all the features. So if you force them to look at the white stuff first, then they can't ignore the white stuff. If you allow the people to look at the black stuff first, then they tend to ignore the white stuff on the outside. In order to get to a final likely malignancy with OA, there's a scoring system that has been developed and validated. Here's a scoring system that we use for ultrasound, and we have a similar scoring system for OA. There are two external ultrasound features. The peripheral zone is scored from 0 to 5, while the boundary zone is scored from 0 to 6. There are 3 internal ultrasound features, shape, echo pattern, and posterior features that are all scored from 0 to 5. Here's a scoring system for OA. There are 2 external features, peritumoral or peripheral, which are scored from 0 to 5, and capsular and boundary zones, which are scored from 0 to 6. There are also 3 internal features that are scored for 0 to 5 for vessels, total hemoglobin, and amount of deoxygenated blush. So there are in total 5 scores that are assigned for OA assessment. So what are the individual functional and morphologic features that we can see? The functional OA features that we can see are the total amount of hemoglobin, which is the yellow map, whether or not that hemoglobin is oxygenated or deoxygenated, which are displayed as the red and green maps, and whether or not there's a blush that we can only see on the bottom center OA relative map. The morphologic findings are the presence or absence of vessels and the morphology of those vessels, whether or not the vessels are similar in size, shape, and orientation, which we call monomorphic, or if they vary, which we call polymorphism. Irregular vessels can represent encasement, which is suspicious for malignancy. We look for these findings both internally and externally. Once again, it is very important to examine the image not only for internal findings, which radiologists do well, but to also closely evaluate the peritumoral area or boundary zone, as well as externally, or the peripheral zone, which traditionally most radiologists do not do well. Now, this is a cancer that's had its feeding arteries and draining veins injected with latex rubber, and then it was dissolved with acid. The 3 zones, internal, boundary, and peripheral zone, are drawn in. You can see that there are very few vessels in the internal zone. You can see that the richest vessels are in the boundary zone, but there are also some vessels in the peripheral zone. Now, most of the boundary zone vessels are new malignant vessels from neoangiogenesis. Notice that most of them are perpendicular to the surface of the nodule. These are called boundary zone whiskers. Notice that the peripheral radiating vessels are paired. That means they are parasitized native vessels, as tumor neoangiogenesis-induced vessels are never paired. So most of the boundary zone vessels are neovessels. But you can see that there are some native vessels that are passing through the boundary zone there. This clearly demonstrates why the tumor model using OA is concentrated in the boundary zone and the peripheral zone, because the vast majority of the vessels are in these two zones, and there are relatively few vessels in the internal zone. Now, those of you doing breast ultrasound may store just still images, but the neovascularity in malignant lesions is often very eccentric. And in this drawing illustrates that pretty much all the vessels are over on the right between 2 and 4 o'clock. If we just got two orthogonal images, still images through this mass, the vessel on top may appear to be a benign capsular vessel, and we would get a false negative. But if we do a short axis video sweep, meaning along the short axis of the transistor to include a centimeter of surrounding tissue, then we will pick up all this neovascularity. So we generally store a radial and antiradial short axis sweep or a longitudinal and transverse short axis sweep in order to make sure we pick up all this eccentric vascularity in the video loops. As it turns out, different grades of cancer, not unexpectedly, look different on OA images. Grade 1 cancer has mostly boundary zone and peripheral zone findings, and often a paucity of any internal findings. Grade 3 cancers, on the other hand, have mostly internal and boundary zone findings, but no peripheral zone findings. And grade 2 tend to be a mixture, more variable, but often have all three zones involved. Because we show blood with OA, people have this mistaken idea that this is just a super Doppler, and this could not be further from the truth. Doppler can only see motion, and Doppler is angle dependent. If flow is at 0 degrees, it sees it well. If flow is at 90 degrees, you can't see it no matter how fast it's flowing. OA is not angle dependent. Doppler also requires a critical velocity. If blood is too slow, it can't see it. For instance, you can't see blood flow in a placental lake with Doppler. OA does not require a critical velocity. The big difference is in the contrast ratio. This means that OA can tolerate a lot of volume averaging where Doppler can't. What does that mean in practicality? Well, let's just say that a voxel is in millimeter. Because the contrast ratio in Doppler may be 1.5 to 1, if that vessel doesn't fill 90% of a voxel, it will not be detectable. On the other hand, OA can have a contrast ratio anywhere between 6 and 20. So let's just take the example of a contrast ratio of 20 to 1. That means that a vessel can only fill up 10% of the voxel, which is 100, if 100 microns in size, and still cause that voxel to light up with a 2 to 1 contrast ratio. So the reality is that a vessel has to be about a millimeter in size to be seen with Doppler. We can see vessels 80, 90, and 100 microns in size at the optimal focal zone in cases with higher contrast ratios. What we're seeing here is the same 6 millimeter invasive ductal cancer, grade 2, showing only a single vessel on Doppler, but on OA, there's a tremendous internal and boundary zone blush and peripheral radiating arteries. And the final thing is that OA can show deoxygenation where Doppler can't. And the bottom line is that this degree of discrepancy is the rule, not the exception. Now, this is the rabbit model of a cancer, and you can see how slow that flow is. There's no way that Doppler could show flow this slow, but OA can actually show stationary blood and much smaller vessels, probably 10 times smaller than Doppler. Let's look at some benign lesions with OA. So this is the benign fibroadenoma. On the right OA image, we see a capsular vessel colored red. Now this brings up a dilemma that often occurs. We showed you how grade 1 cancers have a lack of internal findings, but really pronounced peripheral zone findings, and triple negatives have internal findings, but absent peripheral zone findings. So those are sometimes called discordances. The other discordance that can occur is that red is often worrisome, but not always, as in this case of a benign fibroadenoma. It's a general trend, but you have to remember that every living tissue and every benign lesion has both feeding arteries and draining veins. So what we are seeing here is deoxygenated blood in a draining vein. And in general, arteries are green, and in general, veins will be displayed as red. So colorization is relative. So that doesn't happen 100% of the time, but it's a good general rule. So just because the vessel is red doesn't mean it's cancer. This is very much like MRI. In MRI, you have kinetics and morphology. And when they're concordant, when they agree, there's no problem in the interpretation. But when there's discordance, say the morphology is suspicious, the kinetics are reassuring, then you have a discordance and you have to decide which one to rely more heavily upon. It's exactly the same way with OA. This is a red vessel, but it's perfectly benign morphology. This is a draining capsular vessel, a vein over the back of a benign fibroadenoma. So worrisome color, but with reassuring morphology wins. These are other fibroadenomas. You can see that they have classical draped capsular vessels. This is a small fibroadenoma on the left with an anterior capsular vein, and this is a larger fibroadenoma on the right with a capsular artery. Benign capsular vessels can be recognized by their morphology. They are long, gently curved, oriented parallel to the surface of the mass, and taper gradually. They can be red or green. It should go without saying that for OA to be effective, it's got to help us sort through screen-detected lesions, not only in the 1 to 1.5 centimeter range, but also in those smaller screen-detected masses less than 1 cm. So this is the smallest cancer seen to date with OA. This is a 3.5 millimeter grade 1 invasive ductal cancer. We can see the hypoechoic central nidus and the thick echogenic rim between the aqua and white line is the boundary zone, and inside the white line is the internal zone, and outside is the peripheral zone. Notice that there's absolutely no vascularity in the internal zone. All three internal scores will be 0, but the boundary zone shows a blush, which is a maximum score of 6, and there's peripheral radiating vessels surrounding the lesion, so there's going to be a maximum score of 5 in the peripheral zone. Notice that 2 of these 3 peripheral vessels are paired, arteries and veins, and the third one is green, which means it's an artery. Again, tumor vessels are usually red. The fact that these are green or paired shows that these are parasitized native vessels, not tumor neovessels. This is a luminal A subtype of cancer, which often has this pattern of OA findings. This is a grade 2 cancer. It's positive in all 3 zones, which is typical for a grade 2 cancer. What we're seeing here is a blush in the internal and boundary zones. Notice that the peripheral radiating green vessels. This pattern is commonly seen in luminal B cancers. And this is a triple negative cancer. This shows really intense deoxygenated blush internally, a deoxygenated blush in the boundary zone, but no peripheral radiating vessels. So we have false negative findings externally. There are unique differences in how different grades of cancer appear on OA, and we need to understand this in order to maximize sensitivity. By distinguishing these subtypes, OA can give us powerful prognostic biomarkers. What do I mean by that? OA findings can correlate very strongly with histologic grade, estrogen and progesterone receptor status, Ki-67, but a little less strongly with HER2/neu. So again, to illustrate the differences in how different cancer subtypes appear in OA, let's look at these 3 cases. In the upper left image, we have a grade 3 triple negative cancer, showing intense blush of deoxygenated blood in the internal and boundary zones, but we see nothing in the peripheral zone. In the upper right image, we have a grade 1 cancer. We have somewhat opposite findings, with multiple oxygenated vessels in the peripheral zone and some deoxygenated vessels in the boundary zone, but nothing is seen in the internal zone. Lastly, on the bottom, we have findings in all 3 zones, peripheral radiating vessels in the peripheral zone, and blush in the boundary and internal zones, not uncommonly seen with grade 2 cancers. What was found in multiple studies was that it was pretty easy to teach readers to properly score ultrasound and OA features. But the second step, converting good scoring into a likelihood of malignancy, especially in a discordant case where the external findings were positive and the internal findings were negative, can be difficult. The human mind is difficult at dealing with that. We really like everything to be kind of coordinated. With cancer, we want all the scores to be maximum, and with benign masses, we like them to all be zero. Unfortunately, there's a lot of overlap. But fortunately, what's difficult for the human mind is not difficult for machine learning. There is an AI tool that has been developed to assist readers to better assess a likelihood of malignancy. With machine learning, we can take an incredible amount of data and are able to predict with good certainty a relatively narrow likelihood of malignancy. Components consist of morphologic features, functional features, and various types of patient information. There are a total of 14 different data points that are used to predict a likelihood of malignancy. There are 5 ultrasound feature scores, 5 OA feature scores, and 4 non-ultrasound scores, which include patient age, mammographic BI-RADS, mass size, and depth of the posterior margin of the mass. And this gives us a single output of predicted likelihood of malignancy or false negative rate. Now, what's interesting is that this could be expanded. We could include tire acoustic scores or race. For instance, including Black women or Ashkenazi Jews will have more triple negatives. So there's other factors that could be put into there, but they weren't in the database when this tool was developed. But it certainly would be possible to include additional data points in the future. This is the electronic data entry form for the Sino AI machine learning. You can click on the radial buttons for the 5 ultrasound scores on top, 5 OA scores in the middle, and mammographic BI-RADS, patient age, mammographic diameter, and depth from the bottom drop-down list. Each of these inputs has a reference key that's easily activated by clicking the hypertext buttons. So you could click on the image reference key for the shape score for grayscale ultrasound. They have colored frames, and these frames are color-coded to the PPV. For instance, a score of 0 or 1 have a blue color seen with benign masses, whereas scores of 4 or 5 have a red color corresponding to malignant features. And for OA, a similar type of scoring. And this was found especially useful and helpful for OA interpretation in the beginning. Later on, as they had more experience, they could quickly check these off. At the bottom, there's a single output bar that goes from 0 to 100%, with a black line at 2%, denoting the separation between benign and probably benign categories. You can see in this case, the AI is showing a likely malignancy and confidence interval on either side of the 2% line. To the left of the 2% line is the predicted false negative rate, which corresponds to a BI-RADS 3. And to the right of that line would be a BI-RADS 4A or higher. And where you are along that line, meeting the individual radiologist's comfort level, determines how one would assign a BI-RADS score to this case. These are examples of the AI-generated reports for 2 different breast masses. On the top is a lesion with a very low likelihood malignancy, shown to the left of the 2% line with very tight confidence limits. Below this is a different result with a very high predicted mean likelihood of malignancy, likely in a BI-RADS 4C or 5 assessment category with a fairly narrow confidence interval. At a 90% likelihood of malignancy and narrow confidence range of perhaps plus or minus 5%, this gives us a range of, say, 85 to 95% likelihood of malignancy. This is much more accurate than a BI-RADS 4C assessment category of 50 to 95% likelihood of malignancy. If anybody is interested in exploring optoacoustic imaging further, there are a number of articles in these journals. It was a difficult and long journey, but after 14 years, the FDA gave pre-market approval for the module device to be used as an adjunctive diagnostic test. The approval is specifically for ultrasound evaluation of breast masses that are solid or complex solid cystic with BI-RADS 3, 4, and 5 assessments. So in summary, optoacoustic ultrasound is a fusion imaging technique. It's somewhat analogous to PET-CT, but much cheaper, doesn't require any injected contrast agent. In fact, the patient's blood is an internal contrast agent. It's a fusion of laser photonic light causing thermal expansion and being detected as ultrasound, but it's also fused and co-registered in real time with grayscale ultrasound image. It's a fusion of functional and morphologic imaging. The functional image is the relative degree of deoxygenation. The morphologic is a grayscale ultrasound plus the demonstration of the anatomy of the blood vessels and whether they're suspicious for tumor neovessels. The functional and morphologic data are complementary, they're not just additive. And results show a significant improvement in specificity at exactly 98% sensitivity. Both the strengths and weaknesses of OA and ultrasound complement each other. The system uses an AI model to help the reader use the scoring system to give a likely malignancy of high confidence. At this time, there are multiple published articles in high-impact peer-reviewed journals. If anyone desires additional information, these QR codes are links to publication and clinical trials. Thank you for attending.
Great, thank you so much, Mark. We've got a couple of questions that have come in. The first one is, does this replace an ultrasound system?
Yes, because the Imago machine has both a regular standalone 5 to 18 megahertz probe, as well as the Imago probe when necessary. This machine can completely replace the standard ultrasound machine used for evaluation in breast centers.
Oh, great. And is there a CPT code for this exam?
Yes, so there is a CPT code for the exam. Let me see here. Have that. Are you still seeing my screen here?
Yes, I can still see you.
Yeah, I'm trying to figure out where to. I don't have the codes. I can't find the code real quickly here, but there are codes, which is very appropriate because certainly one would want to be able to bill for this procedure. But yes, there's certainly codes available. I can't get to them right now easily.
Okay, I have been sent the code, so I can tell you the first one is 0857T. And the next one is Opto Acoustic Imaging CPT 3 code. Would you like me to move on to the next question?
Yeah, why not?
Okay. Does the patient feel anything different with this exam than usual ultrasound examination?
Well, not really. A few patients have reported just a slight warmth, which is obviously with the very, very slight heating sensation that you can get with less than 1 degree or less, which is certainly what the FDA has approved. Some patients have reported just a very slight warmth, but nothing that's bothering anybody. The only other thing that the patient might notice is that when the laser is turned on, the patients and anyone in the room, the technologists, put on safety glasses to avoid any remote chance of the laser hitting the eyes.
Okay, I'm just checking to see if we've received any more questions. Okay. Yes. Are there any imaging centers that would not benefit from this modality?
I would imagine, I mean, if the image center is doing breast ultrasound, they would, and giving diagnostic assessments, which I would assume virtually every imaging center and radiology breast center, hospital breast center would benefit. There may be some places doing screening only, but I'm sure those are pretty far and few between.
Okay, another one that's just come in. Is OA pattern different in actively growing cancers without necrosis and cancers necrotic? Hope I've said that correctly.
I'm sure because it's a functional evaluation that there are some slight differences in the appearance of cancer that are growing quickly and those with necrotic centers. But it sounds like what the person is asking is, we're talking about a fast growing cancer like a grade 3 with necrotic centers, and those typically they would still show, if they're growing rapidly with necrotic centers, they would still show vascularity. They would just show maybe a little less in the very center where there's tumor necrosis, because there wouldn't be any blood vessels in the very center of the mass.
Okay, that's good. I haven't got any more questions coming. Is there anything before we wrap up, anything you'd like to kind of touch on again or summarize, or top tips?
Well, to me, this is a very exciting technology. I was involved in the reader studies a few years ago, and the readers were all very interested and excited to see how this would all sort of play out over time, and exciting to see that this device has gotten FDA approval. I'm not financially tied to the company in any way, other than presenting this seminar, but I think this presents a great potential to be able to reduce the number of benign biopsies and improve our specificity, as well as potential for a lot of research going forward. Anytime we have a new technology, whether it be DBT or automated breast ultrasound, there's going to be research going on for 10, 20, 25 years as this technology matures and becomes more refined. And certainly there'll be improvements in the technology as we go forward. This is just a very, first generation, clinical first generation as we speak. And it's exciting to see how this could potentially be applied to imaging for blood vessels, for lymph nodes in the axilla, or to watch patterns for neoadjuvant chemotherapy, to monitor progress that way, instead of having to use perhaps MRI.
Okay, I've just had another question pop up. Is OA real time like us, or only snapshot based? I mean, if it is possible to track vessels and GP in real time with clips.
Well, yeah, the clips that we get and record are all duplex, real-time ultrasound fused with the OA as well. So you'll see in that 601 display, the video sweeps that we take are duplex. So you'll see all 6 frames going at once. The frame update rate is just slightly slower for the OA, but yes, it's all real-time data and not just still images.
Perfect, thank you for that. Okay, another question here. If fully implemented, would MRI scans be reduced?
Well, it remains to be seen, because we don't probably have enough data yet to know. I think we're talking about, I mean, MRI being used for screening, which is, this is not what this is for. MRI used for detect extent of disease, which this is not generally used for. This is used to determine whether or not to biopsy a mass detected by ultrasound, whether it was on a mammogram or a palpable mass, and decide whether to biopsy. So I'm not sure how this would reduce the number of MRIs, except if it might replace some MRIs if it were proven to be a benefit for monitoring neoadjuvant therapy. And if it were an adequate replacement for MRI, then perhaps it could reduce or eliminate some of those.
Perfect. Another question which just come in. Any correlation of tissue stiffness at SWE and OA patterns?
I am not aware of the research on that. There may have been, but I'm not aware of it at this point.
Okay, super. I think that is it. So we can wrap up. So thank you, Marc, for your time today and such a great and informative presentation. It's fantastic. Thank you. So thank you also to our sponsor, Zeno Medical Instruments. So for more information about their products, please visit zenomedical.com. As promised, the answer to today's trivia question is Georgia. So congratulations to our winner, Cindy Winter. Just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 Art Category A CE credit by the HRA, and you'll be able to download the certificate directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and complimentary registration. Thank you all again for your time, and I hope you enjoy the rest of your day.